Osteobites today. My name is Christina Iftoma, and I'm mom to OsteoAngel Dylan and the Director of Scientific Programs at MIB Agents. And today on Osteobites, we are talking with Dr. Chris Collier from Indiana University about unanswered clinical questions in sarcoma, opportunities to move from bedside to bench. Thank you so much, Dr. Collier, for joining us on Osteobites today. We are thrilled to have you. And thank you to Vicki for joining us as our panelist today. Vicki is an osteo warrior and MIB Agents Junior Advisory Board member. Just a little bit more about our guest today. Dr. Collier is a dedicated surgeon scientist who leads innovative basic science and clinical research to improve outcomes for his patients. He's an assistant professor of orthopedic surgery at the Indiana University School of Medicine, and he's authored numerous publications, textbook chapters, and has earned multiple research awards and grants and presented his research nationally and internationally. And before we get started, we have a couple of announcements. We had our Turbo meeting yesterday. Turbo is our virtual tumor board for osteosarcoma, and our next meeting is in September. And then we'll be moving to a monthly frequency and adding meetings at an EU-friendly time to encourage EU participation. If you're a clinician or a researcher with interest in osteosarcoma and would like to be added to the calendar invite, just fill out the form on our website. And patient families, only doctors can participate in Turbo, but you are more than welcome to ask your oncologist to present your case on your behalf. And we have some more events coming up this summer for July Sarcoma Awareness Month. We have our virtual Outrunning Osteosarcoma event. When you run, walk, cycle with us, you can help cause a cure, and we'll put the registration link in the chat. And also, we're partnering with Kendra Scott for a multi-city give back event taking place this weekend, July 15th to the 17th. And if you make a purchase during this weekend, you will help raise funds and awareness for osteosarcoma. And we will put a promo code in the chat that you can also use online when you make a purchase. And then in September, we're doing our bows again. So be bold and go gold for Childhood Cancer Awareness Month. You can make and sell bows in your community or make a donation this summer. And we'll put some more information about how you can get involved in the chat. And thank you very much to the Osteosarcoma Institute, who is our sponsor for this episode. OSI is a nonprofit organization led by osteosarcoma experts from top U.S. cancer centers who together are concentrating on the cure for osteosarcoma. The mission of the OSI is to dramatically increase treatment options and survival rates in osteosarcoma patients through identifying and funding the most promising and breakthrough osteosarcoma clinical trials in science. In addition to advancing research, OSI also provides a free resource called OSI Connect for osteosarcoma patients. Our osteosarcoma experts can discuss available treatments, possible side effects, and provide helpful advice for getting the most out of your visit with your treating physician. And this resource is available in English and Spanish and aims to help patients and families find answers to their questions. And we'll put a link to OSI and Connect in the chat as well. So I'm going to hand it over to Vicki to introduce herself.
Hi, everyone. My name is Vicki Hoy, and I'm an osteo warrior, as Christina said. Actually, a recent survivor, 2 months now, NED. I had to take a gap year off of school for treatment, but I'll be starting at Villanova School of Business next month. I know I got a lot of questions during treatment if I'd be in medicine, but definitely can't do it now. But that's enough about me, and pass it on to Dr. Collier.
So first, I just want to thank Christina and Vicki for moderating this session, and to the MIB agents as well as the Osteosarcoma Institute for the opportunity to talk with everyone. And thank you for taking a little bit of time out of your Thursday afternoon to talk about some things that I think are pretty important, and hopefully we all share that. So first, I'll start with a disclaimer. So I am an orthopedic surgeon. And I do run a basic science lab as well. So I do have a scientific component to my my effort. But a lot of the things that we're going to talk about today do encompass medical oncology, radiation oncology, and various areas of medicine. So even though we'll discuss it in passing, I don't want to give the impression that I'm an expert by any means in some of those detailed areas. So there's a lot of interest and discussion of this idea of bench to bedside research. And just to put it simply, the idea is that in the basic science laboratory, we can take discoveries and work to translate them into meaningful clinical results and better outcomes for our patient. But one thing that I think always struck me in thinking about bench to bedside research is that really the bench portion of this should start at the bedside. And what I mean by that is the bedside may not always be the best place to answer a question, but usually it's the best place to ask one. And really it is our patients and our experiences in the clinic that inspire the questions that lead to the research that we all do, and if not do, then I imagine think is important. So my goal today is going to be to take you through one of my patients' journeys with osteosarcoma. And some of what I'll talk about will be more generally relatable to sarcoma as a pathology, but most of it I'll try and specialize a little bit on osteosarcoma considering the audience. And one thing I want to point out as we go through at the bottom of the screen, this is going to be a timeline basically taking you through the different stages of treatment in this patient's course. So starting off, this is an 8-year-old male. He presented to the emergency department with 4 days of left thigh pain since he felt a pop in the thigh after jumping at swim practice. Avid swimmer, had persistent pain, and when he presented to the emergency room, imaging was obtained. And so I'll walk you through this a little bit. So over here on the far left, we have an X-ray of the femur. And what you can see is that in the middle of the femur, there's a radiolucent or darker area of the bone. And down here we have the knee, and then the hip is just off screen up top. But this area of the bone is a little bit darker, and the cortex, or the outer portion of the bone, is a little bit thinned. And so here we have MRI scans, which show the normal bone down here at the bottom around the knee, and then throughout the femur, there's replacement of that normal bone. And that's suggestive of something, of course, going on inside the bone. And you can see here where this arrow is, there's actually a pathologic fracture through this. So unfortunately, this is how he presented. And of course, the next step was to get a biopsy of this area. And for those of you who haven't seen this, and I won't go into detail, but this is what osteosarcoma looks like under the microscope after it's been taken out. And you can see that there's a bunch of cells. They all look a little bit different. That's all these sort of purplish, bluish circles. And then this pinkish portion right in the middle, that's really what defines it as osteosarcoma. It's that production of osteoid or bone within the tumor. So unfortunately, that's what the diagnosis came back as. And I just wanted to make a couple comments about sarcomas in general and how they're a little bit different, or a lot different, than most of the cancers that we treat. So what I mean by that is when most people think of cancer, they think of a cancer occurring in an older patient, maybe breast or lung or prostate cancer. And what all of those cancers have in common is they're called carcinomas. And they're called that because they arise from glands within the body, so organs that normally secrete something. And they tend to occur at an older age. They're often associated with carcinogens, or things that put people at risk of developing cancer, like smoking or drinking or sun exposure, etc. And they follow a very classic course to cancer. So usually a cell gets a mutation, it gets another mutation, it sort of starts growing a little abnormally, then it gets a few more mutations. It's a stepwise progression until it becomes an aggressive cancer. Sarcoma is different. Sarcoma, these are tumors that arise from the connective tissues. So muscle, bone, fat, tendon. And they're characterized in many cases by occurring in younger patients. Some occur in older patients, but when we're talking about bone sarcomas, we're talking primarily younger and young adolescent patients. And we frankly don't know much about it. We don't know about too many risk factors. It doesn't seem to be associated with smoking or sun exposure. But there are some associations with these syndromes where these major genes, really critical genes, are mutated. And when you get mutations in those genes in a carcinoma, that tumor cell tends to go on and die, and it's not able to turn into an outright cancer. And this is, sort of borne out in the literature, and we see this a lot. So this is a paper from 2018 in Nature. which looked at pediatric cancers over here on the left compared to adult cancers. And here on this y-axis, this shows the number of mutations in the cancer. And what you can see, this is a log scale. So every line here, this is almost tenfold higher than the line below it. And these adult cancers have way more mutations than their pediatric counterparts. They're different. This comes out in even soft tissue sarcomas, which occur in adults. And I won't go through all the details here, but what you can see is all of these colored dots over here on the right, those are sarcomas. And the darker dots, these are not sarcomas, these are carcinomas. And you can see that the colored dots, the sarcomas, have sort of isolated themselves way off in this bottom right-hand corner. And that suggests that there are fewer mutations, but there are a lot more unbalanced breakages in the DNA, which we see a lot of that in osteosarcoma as well. So the questions, and as we go through each one of these stages, I'm going to sort of pose some unanswered questions. And today I'm not going to present really much of my own data at all. It's really meant to be more of a thought-provoking conversation. And so please, if you have questions, feel free to raise them as we go. But unanswered questions, what causes sarcoma? We have some clues, and there's a lot of basic science that has been devoted to this, but we really don't know that much about it. And I get these questions from patients all the time and do not have a good answer for them. Why is sarcoma so rare? Why does it occur in kids, young adults? Why does it occur after radiation? Osteosarcoma in particular is one of the hallmark cancers that we get after receiving radiation for something else. Why does it occur in these syndromes where these major genetic regulators are deleted? And then the other question I get from patients all the time is, why didn't we catch this earlier? To summarize, one of the major unanswered questions is, what pathways give rise to sarcoma development? And that's certainly something that we can use basic science, the bench, to answer that question going forward. All right, so back to the patient. So we've now arrived at a diagnosis of osteosarcoma. And so the next step is to stage, to see if that cancer has spread anywhere else in the body. So over here on the left, we have a CT scan of the lungs. And you can see this arrow is pointing out a small nodule, but it's too small to biopsy. It's in the middle of the lung. And so in this case, it's something that we would observe. But fortunately, they also got a PET scan, and that fortunately did not show any other obvious or clear disease. So at this point, we think that this patient has localized disease. The reason that's true, but also maybe not true, really goes all the way back into some studies that were done in the early 70s and even before. So this is an old paper. You can see it was published in 1972, and this was before modern chemotherapy. So this was back when osteosarcoma was treated with amputation alone or radiation. They had not developed MAP chemotherapy, which is what patients generally receive now. And what you can see coming down row by row, these are the number of months after diagnosis, and these percentages are the survival of the patients. And these numbers are very low, much lower than they are today. And these are patients who did not have obvious metastatic disease based on their scans at the time of diagnosis. And so that has led to the general understanding with osteosarcoma that even if we don't see evidence of metastatic disease in the CT scan, the cancer is likely already spread to the lungs because all of these patients were getting amputation. So it wouldn't have spread later. It must have already spread. So why does sarcoma and osteosarcoma have a propensity to metastasize to the lung? We don't really know. Why can't we detect all of these lung metastases at diagnosis? Well, a CT scan is somewhat of a crude measurement. It's better than a chest X-ray, but really small lesions are unlikely to show up on a CT scan. And then the question is, if we can't detect them, well, and they come back many years later, are these tumor cells somehow remaining dormant in the lung? Are they maybe hiding somewhere else in another bone and then spreading to the lung? And could we detect these lesions if we had better techniques? Probably. Again, all of these are things that we just don't know the answer to, though certainly people are working on. And this brings us back to a basic science question. What mechanisms mediate sarcoma lung mets? If we understood that, then we might be able to answer a lot of these questions above. All right. So now we've staged this patient, and he's going to start 10 weeks of preoperative chemotherapy with MAP, which is 3 medications: methotrexate, adriamycin, and cisplatin. I find this story fascinating, so I thought I'd spend a couple minutes just talking about it. But this is the story of MAP chemotherapy. And, so in the early 80s, late 70s, there were many papers that came out that started to look at some of these medications and showed really tremendous outcomes for patients in terms of increases in survival. These were all retrospective studies. They didn't have any sort of randomized trials. And then this paper came out from the Mayo Clinic, where they looked at high-dose methotrexate, and they basically showed no difference between chemotherapy and no chemotherapy arms. That then prompted this editorial in the Journal of Clinical Oncology, which was pretty scathing. And it said, that these major cancer centers needed to put aside their desires for individual achievement. And they said there's no excuse for giving these chemotherapy drugs that have not been proven without a randomized controlled trial. And so that prompted a couple randomized controlled trials in the 80s. And as you can see, this top line, those are patients who received chemotherapy compared to those who didn't. There's a huge difference. And we know that now, that chemotherapy is very effective. And that was repeated in this study as well. This is another editorial that came out shortly thereafter, and again, scathing. And basically the point they're making is that these randomized controlled trials were unethical because we already knew that this worked, and they weren't necessary, and unfortunately held back therapy from a bunch of kids that would have done better with it. And so the point they're making is that in the absence of strong, non-randomized evidence, we don't always need to have the perfect or gold standard study. I think that's important to keep in mind as we think about all of these questions. But we still have many questions about chemotherapy. Do all patients need it? I just showed you that maybe 20% of patients will survive without chemotherapy. If we had a way to predict which patients that was, then we could save these patients from a lot of toxicities later in life. Can we predict the effectiveness of chemotherapy? And there's some general questions about other types of sarcomas. And the question that I get a lot, why not surgery first? All of this comes down to this idea that we need to be able to better determine why certain tumors are not responsive to our conventional chemotherapy so that we can develop other therapies and treat them more effectively. So patient went through—
Dr. Collier, actually,
yes.
Sorry, can I interject with a couple of questions? Just to your point earlier about the whole randomized versus control, which I don't think is done much these days just because of that whole issue of like, no patient wants to go on the placebo arm, right? And that question actually came up at our Factor conference recently. And what are your thoughts about? I mean, we actually have. You can kind of maybe consider like the if you're comparing different arms like MAP, which is kind of the established protocol today, versus other treatments that we kind of actually have a lot of historical data for MAP alone, and kind of basically using that historical data as the control arm. Like, do you think that works? Because again, it's just like most patients are going to want to, when they're enrolling in a trial, they're going to want to receive the therapy.
Yeah, I think, again, I'm not a medical oncologist, so I don't, if there are some listening, I don't want to dive too much into, trial design. But, my personal opinion is that, and we do this in the basic science lab when we're looking at new therapies, that everything should be compared with probably the gold standard, which is MAP therapy. So I would imagine, we know that MAP is incredibly effective and it saves many lives. So if you're looking at a trial in the primary setting, it probably needs to be MAP therapy plus something else in one arm, and then MAP therapy by itself in the other arm. right now, most trials are done in patients that are relapsed or patients with metastatic disease that do not seem to be responding to MAP. And so to your point, it is very hard to kind of go backwards and develop a clinical trial for people in the primary setting when they haven't received any treatment at all. But I think MAP has to be probably present in both arms. But historical controls could be used too. It's just, there's a lot of sort of statistical issues with doing it that way.
Mm-hmm. And then just another question about the whole why not do surgery up front. And so my impression had always just been that the tumor was easier to remove after some initial chemotherapy, just kind of, otherwise it's just harder because it's this juicier tumor that's hard to remove versus after chemo, it kind of calcifies a bit. It's like cleaner to remove. I don't know if is that true? And I mean, I know there's some utility, like you mentioned, for being able to evaluate the effectiveness of the chemotherapy and to get like a necrosis number. But also it just seems like the necrosis number is kind of interesting. I know that's kind of been one kind of risk stratification data point that's been used, but it doesn't seem like it's necessarily like a great number to use, just because you can have high necrosis and still, relapse. And they're just kind of curious about that. Like, is it possible to do upfront surgery, or is it just easier to do the surgery after some initial chemo?
Great questions. And, as I alluded to, it's one that I answer most of the time when dealing with a new diagnosis. A couple thoughts. So first, there has been a study that was done in the early 2000s looking at upfront surgery. And, essentially what they showed is that there was no difference in outcomes. So it's probably a safe thing to do. Again, limited study, but it was randomized, and, they had a couple hundred patients in each arm. My personal feeling is that the benefit of doing chemotherapy first is a couple things. One, yes, maybe it makes the resection a little easier. Osteosarcomas usually don't shrink, but it probably helps develop a little bit of a capsule around the tumor that makes it easier to get negative margins. It also probably treats some of the small cells or satellite cells that have split off from the primary tumor a little bit. And that way, when you're going in to do surgery, you're not spreading those satellite cells around further. More practically though, doing chemotherapy up front gives you time to talk to the family about, their decision on limb sparing surgery versus amputation versus rotationplasty. And, in my experience, those are really challenging discussions, and it usually takes a lot of time to make those decisions. It can take time to plan those surgeries as well and get necessary implants, et cetera. So, trying to kind of rush that timeline, while doable, I do think has some drawbacks. The benefit might be, for a lot of patients, it can decrease some of their anxiety, and a lot of them just want the cancer out as quick as possible. And certainly I understand that. But, I think the way that a lot of the protocols have been designed, they're pretty etched. And, trying to change that paradigm of doing chemo first is sort of, I think, a challenge. I hope that answers that question.
Yeah, that's a really good point, because I do remember those are some really big decisions to make around that primary surgery. So that it would be really difficult to make so close to diagnosis. And to your point about like the mets, like likely mets, giving the chemo, I guess, up front gives you a chance to start attacking that. All right, thank you.
Just another question before we move on. How long does it usually take to make the implants? Like, when's the earliest someone could, if they were going for like limb salvage?
It depends on the surgery. So, for example, if someone's getting a endoprosthesis or say a knee replacement, a piece of metal, That most of those are off the shelf at this point. So they're available. You probably just need a few days notice. There are some cases where, say, it's a tumor in the pelvis bone that requires a more specialized prosthesis, if you even use one, and that can take 6 weeks or so. An allograft, which is just a cadaver bone, not metal, depending on what part you're looking for, usually you can get that in a week or 2. So it really depends on the reconstruction. But again, I have found it valuable, and I think my patients have, to be able to kind of have a few different touch points and a few different discussions along that course of preoperative chemotherapy to make sure that they're really invested and feel like they're making the right decision for them or for their child. Yeah. Well, that's a good segue. So speaking of surgery, so we had these discussions with this patient and their family, and ultimately they decided on having an allograft reconstruction. And so I'll show you what this looks like. So, here we're looking up at the hip joint. It's a ball and socket. And this patient had a very long segment of bone involved by osteosarcoma. So this is a plate and a second plate. And right here, that's where the allograft, the cadaver bone, is meeting with his normal bone here. And that comes all the way down until we get to the knee. And again, I cut right above the growth plate here, and then was able to get fixation around that. So this is all cadaver bone. That's where I cut the bone, and then this is his normal bone. So we're able to preserve the hip joint and the knee, and in between, that's all bone from someone else. So I'm a surgeon. I could make this list go on forever, but there's a lot of questions, and I think the most important one is the one we just discussed. It's how do we improve surgical decision making? And I don't mean that just from the patient's perspective or surgeon's perspective. I really mean both. How do we get the patients more comfortable with their surgical decision? And how, as a surgeon, do I get better data to help select the best option, or at least inform my patient on what might be the best option for them? And within that, I think there's a lot of ways that in the lab, we could improve this. And one of the key ways would be figuring out a way where in the surgery, we can actually localize the tumor. Because right now, we do this primarily by just measuring from landmarks with a ruler, and that's why we're required often to take a fair amount of bone on either side of the tumor. But if we can develop better ways to visualize the tumor in the surgery, we might be able to save a little more bone and ensure that we're getting negative margins. So patient underwent surgery, margins were negative, so we're patting ourselves on the back. And he had 75% necrosis. We'll talk about that in a second. But then he went on and he started his 16 weeks of continued MAP chemotherapy. I did throw in a little bit of my own data, but this is a paper that we're working on publishing now, just got accepted, that looks at this percent necrosis, as we already talked about. So this is the amount of cancer that after surgery, after it's been removed, is dead when you look at it under a microscope. Necrosis just means death of the cancer, simply. And that suggests, if it's high, that the cancer responded well to the chemotherapy. So the chemotherapy worked. And there's been a lot of studies looking at, what cutoff is predictive of better outcomes. And, we showed essentially what's been shown before, but in a larger group of patients, that 90% level is pretty good. But Christina, to your point, it doesn't really matter what the percent necrosis is if you're one of those 20% of patients where the cancer has not spread to your lungs. In that case, if you've resected all the cancer and it has not spread to the lungs, then necrosis could be 0 and you would still be a long-term survivor. So this is just part of the picture. It's certainly not the whole picture. But one question that I have a lot is, we give these patients an additional 16 weeks of chemotherapy. If the tumor has 100% necrosis, do they really need that? We do it all the time. But there may be a way to predict, which patients don't need that additional 16 weeks, which comes with a great deal of toxicity. And so really a lot of this is going to require some research models that are going to have to look at how we can personalize the therapy for osteosarcoma patients. And that may also help us in patients who are poor responders, who have a really poor percent necrosis, add additional medications or change the therapy in order to get a better outcome. All right. So this patient, so far, everything's going pretty well. And so he's on to the surveillance portion of his treatment. And these are the guidelines that the National Cancer Network provides, which is a big organization within the US. And you can see that here, these are what they typically recommend. So this patient needs to continue to have imaging of the chest and imaging of the leg at set periods, essentially forever, according to this. But we don't really know, and a lot of people will vary from place to place, what the best way to do this is. And what I mean by that is some people do PET scans, some people do chest x-rays, some people do CT scans. It really is institution specific. And there are probably emerging ways, it's too early to say, that we might be able to do this better without exposing kids to a lot of extra radiation through an x-ray, PET, or CT. And one of those is circulating tumor DNA, where you actually just do a blood test, and you can look to see if there's any tumor in the blood. And that's being explored right now in a variety of cancers, and hopefully will be coming at some point to sarcoma if it works. So overall, we really need better biomarkers in the blood, because that could replace some of these conventional surveillance strategies, perhaps with more accuracy, but hopefully would help reduce some of the toxicities of radiation that's involved in screening. So this patient, unfortunately, did eventually develop a relapse. So this is a CT scan of his chest, and you can see this circular sphere in the corner of his lung. This was biopsied and consistent with an osteosarcoma. And so we underwent resection of that, but it was just that single nodule. And so after discussion at our tumor board, the decision was made to not give any additional chemotherapy. But when relapse does occur, there's a ton of questions that come up. Was the tumor already there? Or did it spread from a recurrent area in the primary site? Why did it recur? Was it resistant? Was this a specific cell within the tumor that was resistant to conventional chemotherapy? And when it occurs, should we give additional chemotherapy? Should we give the same therapies? So putting all this together, we really need to ultimately develop new drugs for this scenario, because there probably is some resistance that's developed. And there's a ton of new drugs that are developed in cell culture on a plate in a lab or in a mouse. But the challenge is trying to figure out which one of those drugs is best to get in line for a clinical trial. Now, this is a different patient. This is not the patient I've been talking about, but I just put this up as an example. So this is a patient who has extensive metastatic disease. All of these lesions within his lungs, you can see how different they look, are large and progressive, and ultimately this patient passed away from his disease. And for me, as a surgeon, and certainly for our medical oncologists who have many of these really difficult discussions, one thing that we are not very good at is helping a patient and a patient's family decide when to stop treatment. And if there's a way that we can predict incurable states earlier, we may be able to save the patient a lot of distress through therapy and improve their quality of life with what time they have. And I think this is something that we don't talk about much, but really would make a dramatic difference for these patients at this stage. All right. So this is my last little section, and then I'll bring it to a close and then open it up for some questions. So fortunately, the patient now is 18 months, and I actually just saw him last Tuesday in clinic after his resection, and he doesn't have any evidence of disease. And, from my standpoint, we're very fortunate with his leg. He healed both of these junction sites, even though it's a long segment, and he's walking with really a pretty minimal limp. It was pretty impressive. Even around the 6-month mark, he was literally crawling on the exam table, and I had to hold him back. So really a fantastic outcome. And while all that's wonderful, we know that kids who've received chemotherapy or have had limb sparing surgery, this is a lifelong issue for them. And this is a paper from 2020 in the Journal of Clinical Oncology that looked at pediatric and young adult patients with cancer. And they looked at how many comorbidities, meaning other health problems, did they develop over the course of their life. And each one of these x-axes, this is the years since diagnosis, and the red line is a non-cancer patient, so a normal person, or a normal non-cancer individual. And then in the blue line, this is someone who's survived cancer. And the higher that line is, that means the more comorbidities they have. And you can see that the difference is quite dramatic. So we need to understand better why these long-term toxicities occur. Are they all chemo-related or some tumor-related? Are there ways that we can mitigate them? Maybe other medications, maybe ways to target the chemotherapy so it doesn't affect the heart or the lungs. And then for the leg itself, in this case, are there ways that we can prevent infection, prevent non-union, chronic pain? I mean, these are massive surgeries, and this leg is never really going to be the same, but hopefully in the future, we will continue to get better at this and reduce some of these long-term issues. And then, of course, there's an incredible amount of mental health, anxiety, coping. You know, this is an unbelievable ordeal that I can only imagine going through. But having seen many kids go through this, it's important that we recognize that they might need help, and probably most will. So looking at, in the future, mitigating some of these long-term effects of cancer treatment. So just a couple slides to close. This is what my 8th grade English teacher told me. And so I know I've presented a lot of questions and questions and questions. You can tell I might have gotten on her nerves a little bit. But hopefully in the future, we'll develop some answers. And fortunately, I'm not the only one asking questions. So this is a fairly recent paper that includes a lot of big names within the medical oncology world. And these are provocative questions regarding osteosarcoma. And all of these questions, for the most part, really focus on better understanding the biology of osteosarcoma and working towards developing new therapies. And that's got to be goal number one, you know, because this is a graph that shows survival for patients with localized disease at presentation over time. And you can see that for a while before chemotherapy, only 20% of patients survived. And then there was this dramatic improvement with chemotherapy. But since, we've really had a plateau, we have not had much improvement. And that's especially true for patients who present with metastatic disease. We really haven't seen much improvement at all in survival. So clearly, priority number one needs to be to develop new therapies for osteosarcoma. But I hope that in this talk, I've made the case that there really are many other opportunities where we can take what we're seeing in the patient through their different stages of treatment and move that into the lab, or on the clinical research side, a computer desktop, if you will, and translate some of those findings there back to the patient. And that's ultimately the goal. And I'd like to just end, you know, maybe with a little bit of a hopeful message. This is the patient that we've been talking about. As I said, I saw him last week, and he just qualified for state and junior swimming. So really is doing wonderfully. But hopefully with all of your help, and for me being at the early stage of my career, I guess maybe I'm still a little too hopeful perhaps, but I do think and I do hope that we can find some answers to these questions, and look forward to hearing some questions from you all. So thank you for your attention.
We have a question from Sabine, and the question was, what factors suggest the need for additional treatment? And just for some context, she said that her son had a recurrence after 9 months, and after a reaction from his oncologist, he was put on Votrient, I think it's pronounced, and that other patients don't take any treatment and remain no evidence of disease, but her son relapsed after 2 and 5 years on Votrient and had many unpleasant side effects from it.
Well, Sabine, thank you for your question. I think that's certainly an area where a lot more work needs to be done. You know, we certainly know that certain factors like the size of the tumor, the location of the tumor, the grade of the tumor, percent necrosis, all of these things are associated with a better or worse prognosis. But we don't really know which of those factors are clearly associated with response to conventional chemotherapy. I did show you a little bit of data from a paper that I mentioned, and in that paper, we looked at what factors, which of those might be associated with a lower percent necrosis, which would suggest a poor response to chemotherapy. It was, for the most part, the usual predictors, but one thing that was interesting is the presence of metastatic disease did not predict a response. And it was really more of the grade of the tumor, the size of the tumor, and actually some socioeconomic factors suggesting that maybe some patients didn't have as good of access to care. But yeah, I hope that I'm able to answer that question better in the future. But if we could find a way to predict which patients needed a different drug, that would really make a big difference, I think. So hopefully we'll get there. Thank you for your question.
Thank you. I also had a question just coming from me. I had an implant in my pelvis, but there was never any option for any other kind of surgery. And I know that cadaver bones are usually used in femurs and fibulas, but has it ever been like questioned if they can be used in the pelvic bone?
So I'll say first, you know, to answer your question, I guess I'll start it this way. Yes, a cadaver bone could be used in the pelvis. Generally speaking, we've moved away, I think, as orthopedic surgeons from using a cadaver bone that includes part of the joint. And the reason is the joint is always cadaver bone. It's always dead bone, and around a joint, that bone tends to collapse and degrade very quickly. So you don't get as good of outcomes as you might see in this case, where we were able to preserve both sides of the joint at the knee and at the hip. But with that said, you know, every tumor is different, every location is different, and certainly not all options are available in every case. And so, you know, I'm sure that the surgeon that treated you, Vicki, was thinking about all those options, and it may have just been that, you know, a cadaver bone was not a good one in that situation.
Also, just another question from where I'm coming from. If I have an implant as well as a hip replacement, is there one that will need to be replaced sooner, or would they both? Because I was told I might have to have surgery every 15 to 20 years. So would it just be the hip replacement that needs to be done, or is it usually the implant as well?
I would view those as one and the same. So really the hip replacement is probably part of a larger joint replacement. But it's hard to comment too much, Vicki, without, you know, kind of understanding your story a little bit more. But yes, we know that these implants will likely wear out. The hope is that some improvements recently in joint replacements will hopefully make things last longer. But when you're putting a joint replacement in a young kid, you know, your demands are going to be very different than a 70-year-old or one of our grandparents who gets a hip replacement. And it's many of them are not really designed specifically for the purposes that a young person would often, you know, demand of them.
Dr. Collier, I had a question about, and you had mentioned this a little bit, talked about the pathologic fractures and just kind of what the understanding is around that these days. Because I think initially the literature around that was that, you know, pathologic fracture was linked to worse prognosis. And then I feel like there's been some, you know, some thought recently that, you know, is that really the case, or is it that it's more just like a symptom? It's indicative of something else, because if you have a pathologic fracture, it means the bone's weaker, and that. So could you just provide your thoughts on kind of what the thinking is around pathologic fractures and linked to prognosis and outcomes today?
Yeah. So you're right. Historically, back in the 70s and 80s, and in particular before chemotherapy, if you had a pathologic fracture, that was a clear indication for an amputation. And the concern was that the tumor, if you have a fracture, has now spread through the bleeding that occurs throughout the area of the leg involved. With chemotherapy, people have kind of pushed that envelope over the last several decades, and there have been a couple studies that have looked at this and essentially shown similar rates of local recurrence in the setting of a pathologic fracture treated with amputation or limb-sparing surgery. And so it seems to be safe. In theory, is there likely more contamination? Yes. I think that's true, and that's a discussion I have with my patients. I tell them, based on this limited data we have, I think it's safe to still try and save your leg, but there is likely, in theory at least, an increased risk of the tumor coming back there. And so that's a discussion I have, and certainly the degree of displacement of the fracture, how much it's moved, where it is, all those things might modify that slightly. But I've had a couple kids in the last couple of years that have presented with pathologic fractures, and I've managed all of them with limb-sparing surgery. So I think it's in general safe to do. And yes, you're also right. There is some evidence to suggest that if you present with a pathologic fracture, it might be worse outcomes overall. And that's kind of separate from the local recurrence issue. That does suggest that maybe the tumor is likely bigger than it otherwise would be, and has broken through the bone. And we know that those factors are associated with the worst prognosis in general.
Just another question from the chat from Ian Holsworth. He asks, other than circulating tumor DNA tests, are there any other tests for patients to identify osteo that is potentially within the lungs in a patient that is currently non-metastatic under standard scans?
Great question. So I want to be clear, circulating tumor DNA is by no means established technology for sarcoma. So to my knowledge, other than research studies, people are really not using that in standard practice. There is a lot of interest, and at one of the last big cancer meetings, there were 4 or 5 abstracts presented about sarcoma in general and circulated tumor DNA. So I think it's coming. The issue with it will be, does it lead to false positives? Meaning, if you get a blood test and it shows some circulating tumor DNA, that doesn't necessarily mean that the tumor has grown or is large enough to actually cause an issue. It may just be some residual tumor DNA left over from your resection, or it could be an error in the technology. And so there is a potential that, a lot of patients could be kind of put through a process where they're very anxious and they think they might have a recurrence of cancer, but they may not. And we just don't know any of that yet. So I just would pull back a little bit maybe. I'm very excited about it. I think it's promising, but we're just not there yet in terms of really knowing how useful it will be. Short of that, I'm not aware of any other real biomarker or blood tests that you can use to look at recurrence for osteosarcoma. And so right now, the gold standard really is a CT scan plus or minus a PET CT scan, and looking at it that way. But hopefully we'll be better in the future.
Thank you. And another question was, is there magnetically expandable hardware for upper tibia internal prosthetics? He has a 10-year-old patient who had a knee and 10 centimeter upper tibia replacement, including a growth plate. He said, we are looking at options for limb lengthening surgery in the next year.
Yeah, good question. Again, I've kind of alluded to this, I hesitate a little bit making medical recommendations just because without having met you and reviewed your imaging, it's hard to say. But generally speaking, there are magnetic expandables out there. Right now, the main variety is used in Europe, and that's a Stanmore prosthesis. There's been a lot of effort. Stanmore was acquired, I believe, by Stryker, and now another company is working to actually pick them up in the United States. But as far as I know, that is not FDA approved in the United States right now. There are very complicated pathways where it could be used, and people have used that in the tibia in the past. The only issue in the tibia that's unique is there is a nerve in the tibia that's under a lot of tension. So as you lengthen the tibia, can put a stretch on that nerve. So you just have to do it slowly and carefully. But it is out there. It's just hard to get that technology in the United States right now.
To that point, could you talk?
Go ahead.
Oh no, I was just going to say, like on that topic, could you just talk about what are some of the newer developments in the prosthetics world that that you're most excited about? So I know there's some things specifically like infections always such a big issue. So things to help minimize infection, like special coating on the prosthesis, or just the material that it's made out of is something that would minimize infection. And I don't know what other new developments there might be that if you could maybe speak to some of the things that you're most excited about or you think are most promising.
Sure. So I guess a couple things. I don't have any personal experience with the infection coating, but I know, again, in Europe, they're using a lot of silver coated prostheses. We just haven't been doing that much in the United States. But a couple things that I have been using that I think are really interesting technologies. One is not that old, but I think it's, not that new, but it's increasing in popularity. And that's the compress device, particularly for young kids. And this is a device that actually was developed in San Francisco, Christina. And it is really nice because it preserves bone. And the goal of it is to basically get the bone to squeeze to the prosthesis and for the bone to then grow onto the prosthesis, with the hope that that will lead to a longer lasting, more biologic construct than what we usually get with just a stem going into the bone. So I've used that a lot. I think that's a wonderful technology, and we're starting to get longer term outcomes for that. But again, it's not right for everyone. And I should make that clear on everything I'm about to say. The other thing that I think has increased in popularity is the idea of patient-specific cutting guides. So the old way, and I shouldn't say old, I mean, it's still done probably more frequently, but historically, when you're removing a piece of bone, you would again just measure from the joint or some other landmark with a ruler in the operating room, and then you would use a saw by hand to cut that bone. We are now, because of 3D printing, increasingly using patient-specific cutting guides that actually you get a CT scan, and then you can take, it's a plastic guide that's sterile, and you place it on the bone. It's designed to fit onto the bone, and then you pin it in, and then you can cut along specific trajectories. And in theory, it allows you to match up the allograft, if you're using an allograft, more precisely to the cuts you've made in the bone. And in the case that I presented, I actually used those cutting guides, and I think that helped quite a bit in what would otherwise be a pretty complicated resection by hand. The other thing that I'm excited about is on the metal side. There's a lot of interest in 3D printing for prostheses. So that is really useful around the pelvis in particular, where historically the debate has always been, should you even reconstruct someone who has, meaning should you put anything back after you take a tumor out in the pelvis, or should you just let that limb shorten? And oftentimes the patients can walk, but they walk with a significant limp or disability. Now they're able to 3D print metal implants that match specific cuts you make in the bone, and they can do a lot of really unique things as far as putting screws and trajectories to make those more stable. So I think that has made it a little bit more appealing to try and use some of these big metal implants in pelvic defects. And the last thing I'll say, this is just a plug, because I don't think that the device industry is really gonna catch on to this unless we kind of say enough and make enough noise. I think one day, I hope 10 years from now, we will be using robotics to make a lot of these cuts. There's some navigation that people are doing now, but for total knees and total hip replacements in 70, 80-year-olds, they're starting to use the robot a lot to make very precise cuts. Orthopedics, oncology is a perfect indication for that. There's no cut of the bone that is more high risk than that. But the problem is the market's so small, they don't want to design the software to do that. So I hope eventually, as this technology becomes more available, we'll use robotics much more in these resections.
I just want to jump in because I haven't heard many other surgeons talk about the 3D printed and other robotics. And I know that I got a 3D printed implant and the surgeon had help with robotics, but I have yet to have another osteo warrior who's had the same experience. So it's cool that you mention it.
Yeah, that's wonderful. Yeah, I think it is becoming increasingly popular. So hopefully the outcomes will justify it because it's expensive. So yeah, it'll be exciting to hear how you do with it.
Yeah, I mean, it's definitely the most I've spent in one day, and I wasn't even there for it. But just another question from Sabine. She kind of just asks, I know you don't have a crystal ball, but what time frame are you anticipating for new breakthroughs to come? If there's any evidence of things coming soon, or it's kind of not in the works right now.
Yeah, it's a really good question. And I don't know that I have a great answer. I guess looking to other cancers, I think that we've seen a lot of breakthroughs recently with some of the immunotherapies, for example, on many of the carcinomas. I guess I just have to say I hope that sarcoma is close in line. I think it's not just therapies where we need breakthroughs. I think it's all aspects of care. And really the only way we're going to get there is just continuing to do the work and push. And I think all of you being here and being engaged and inspiring people like me to do this work is really going to get us there quicker. So.
Thanks so much, Dr. Collier. That is a good segue to us having to close out today. Thank you so much for a very thought-provoking presentation. And we're so happy that you were able to join us on OsteoBytes today. And thank you for making it better for oncology patients everywhere. More information on this and all OsteoBytes can be found on YouTube, on our website at midagents.org, and also at your favorite podcast place. And next week, instead of our regular OsteoBytes, we're going to be dropping the second episode of Osteo, which Vicki can probably tell you more about, but it's our new AYA podcast from Osteo Warriors and MID Agents Senior Advisory Board members, Vicki, and also Camille, Kerrigan, and Mia. Make sure to check it out, and then join us in 2 weeks on Thursday, the 28th, when we return with OsteoBytes to speak to Dr. Brian Crompton, who's a pediatric oncologist and physician scientist at Dana-Farber Boston Children's Cancer and Blood Disorder Center. And he's going to be giving us an update on the Children's Oncology Group Initiative Project Every Child. And actually, I also wanted to mention, just because we were talking about liquid biopsies before, Dr. Compton does a lot of work on liquid biopsies, and he actually just did a webinar yesterday with Alex's Lemonade Stand on their series. So if you're interested, you can probably go to their site, and I would imagine they have a recording if you wanted to learn more about that from Dr. Compton. Thank you again to Dr. Collier and Vicki for spending an hour with us today, and to our sponsor, the Osteosarcoma Institute. And thank you for joining us today on OsteoBytes. Tune in next week for our second episode of Osteo, and then we hope to see you on the 28th when we talk to Dr. Compton. And in the meantime, go to our website at midagents.org to sign up for Outrunning Osteosarcoma and to order a bow for Childhood Cancer Awareness Month in September. And thank you all so much. We'll see you soon. Thanks, Dr. Collier. Thanks, Vicki.